Hi, this is Dr. Bernstein with our June 2017 Teleseminar. Before we start, I want to give you the usual warning, namely that my answers to questions are intended for the listening audience, not necessarily for the questioner, because I have not gotten a complete medical history or examined the questioner. There's a very good likelihood that my answer may be incorrect. I just don't have adequate information. But the information I give might be of interest to the general audience. Now, we have a special subject this month, namely, there's now a dilutable basal insulin for those who require small doses, especially children. Why would we want to dilute basal insulin? Well, I weigh about 112 pounds. 1 unit of Levemir insulin, which is what I use. Actually, I use Tresiba, but I was using Levemir until recently. 1 unit of Levemir would lower my blood sugar about 60 milligrams per deciliter, spread over the course of a day or so. But if I wanted to change the effect over the course of actually 18 hours to 10 milligrams per deciliter, I couldn't do it unless the insulin were diluted. For kids who, let's say a kid weighs a quarter as much as I do, 1 unit of insulin would lower her blood sugar 240 milligrams per deciliter. So the effect of insulin on small people is horrendous, and insulin is not supplied mildly or weakly enough to be able to get fine-tuning of doses for small people. So now, by the way, we had a dilutable insulin for years and years, Ultralenti, which made it very effective for children. Until we get a new insulin with diluting fluid, we have to usually give multiple doses per day of diluted NPH insulin, which is not really long-acting, so you have to take it every 6 hours or so. So now we have, out of the blue, a diluting fluid for Levemir insulin. For those of you who are watching our Diabetes University video, you'll actually see a picture of the container of the diluting fluid as it is supplied in the United Kingdom. Now, after much inquiry, hedging, and difficulty getting a straight answer, I finally learned that the diluting fluid being used for Levemir in the United Kingdom is the same as the diluting fluid being used in the USA for regular insulin and for Novolog insulin. And that diluting fluid should be available in the USA at no charge. Your pharmacist should be able to obtain it from the manufacturer, Novo Nordisk, and your physician should be able to order it directly from Novo Nordisk also. In the United Kingdom, I think it's sold. I think you have to pay for it, but I'm not certain. It may be available in other countries, but wherever you live, remember that there's been a diluting fluid for Novolog insulin and Novolin R, regular insulin, for many years, and it probably exists in your country, and you could use it for diluting Levemir. You cannot use it for diluting any other long-acting insulin like Tresiba. and you can't use it for Lantus either. The diluting procedure is described in great detail in my book, Diabetes Solution. So if you want to learn how to dilute your insulin using this diluting fluid, go to Diabetes Solution. Or you could go to a compounding chemist, ask him to purchase the diluting fluid, or you could provide him with the diluting fluid, and he can provide you with diluted insulin. First question: what blood glucose level will trigger hypoglycemic neuronal health? I have no idea what this person is talking about, but I should give you an interesting story. When I got my very first blood sugar meter, the big one that weighed 3 pounds, I, over the course of the first month or so, had a blood sugar that read 0. And I knew the meter was correct because in those days, the strip changed color. And here the strip did not change color at all. And I repeated it with another strip, did not change color. So my blood sugar was really 0. And did I die? No. Because of the blood-brain barrier, the glucose level in the brain lags behind that of the rest of the body because glucose diffuses in and out of the brain very slowly. So I could have had a blood sugar of 0 in my body, but it might have been 70 or 80 in my brain at that time. So you can survive with a blood sugar of 0, but it's not going to last forever. You better do something to get your blood sugar back up. As far as this question goes, it has no meaning, and I just used it as an opportunity to tell you that blood sugar level is not the same as brain sugar level. There's a time lag. Are there any vitamins or supplements you can recommend to help in lowering blood sugars along with your diet and exercise? Well, if there are, they certainly would not be of value for people who require insulin, type 1 diabetics or severe type 2 diabetics. There are some very mild type 2 diabetics. In fact, the American Diabetes Association might call them pre-diabetics. I would call them diabetics because their A1Cs might be 5.4, 5.5, 5.3. So these pre-diabetics might find certain substances that might lower their blood sugars. Many of them are unsafe or even dangerous, but there is one that's widely used, namely fenugreek. The unadulterated fenugreek has a terrible smell. You would not want to be in the same room with someone who used it, but there's now a deodorized fenugreek available in some countries, and it might have a small effect on blood sugar, but large enough for people who have only borderline diabetes. And I can't say I recommend it. I had one patient who used it, but I couldn't tolerate him in the room because it was intolerable for me, and I did not want to keep him as a patient. And there were no successors to this patient, so I really don't know if there are long-term adverse effects and so on. Type 2 with an A1C of 5.4 on metformin 2,000 milligrams a day. At what point do you think I should stop the metformin? Well, if your A1C is 5.4, and if normal is, say, 4.2 to 4.6, I don't think you should stop the metformin. Maybe it should be increased. Well, 2,000 milligrams a day is the upper limit if you're taking the time-release metformin. So you might need further medication, or more likely, you're probably not on a low-carbohydrate diet. That will do much more than the metformin alone. So I'd suggest you read my book, Diabetes Solution. One point I should make, however, about a hemoglobin A1C of 5.4. There are plenty of people, in fact, with A1Cs around 5.3, 5.4, 5.6 even, who have normal blood sugars around the clock when they measure them with an accurate meter. I just had 2 such patients today. They both had A1Cs around 5.5, but they never show a blood sugar during the day or even in the middle of the night higher than 100. And 5.5, according to the formula I've been using for years, is an average blood sugar of about 120. So clearly the A1C did not reflect their true blood sugars. And there are many factors that can affect the A1C other than blood sugar. For example, the age of the red blood cells. The older your red blood cells, the higher the A1C. We can estimate the age of red blood cells by looking at the size of the red blood cells, which is reported when you get a blood count, mean cell volume. It means the volume of a single cell. And there may be dietary and medication substances that affect A1C but don't affect the blood sugar. There are a number of supplements that prevent glycation of proteins, and all of these will lower the A1C without lowering blood sugar. I know I should test more often, but the lancing pain is so bad that I cheat and don't test. Is there any way I can obtain a blood sample to test without pain? Well, when I first started checking my blood sugars, I actually used the needle from an insulin syringe to stick my fingers because we didn't have any lancing devices, and we didn't have disposable lancets and so on. But nowadays, there's no reason for the finger sticks to hurt. You have to be doing something wrong. So what I would recommend is, first of all, you get the Gentel, Gentel, Butterfly Touch lancets. And these have a sharper point than most lancets. And they're also annealed so they don't get dull as readily. You can reuse them. And I also like the True Draw device that you can purchase from most drugstores. I think it cost me $6 each, and they're very easy to use. And use the Gentel lancet and a True Draw device. You set the device so that it does not make a painfully deep puncture. You want a puncture that just gets blood without causing pain, and you shouldn't have a problem. Okay, my daughter has type 1, and we have been doing a low-carb diet for almost 2 years. Her LDL was high, 150. I heard that only 1 to 2% of diabetics will have an increase in LDL while on a low-carb diet. Do you know anything about this, and do you have a solution? Well, usually, first of all, I've said this many times on our teleseminars and on the Diabetes University videos. LDL by itself is not really a marker of cardiac risk as they used to think. A better marker might be oxidized LDL, which you can measure, glycated LDL, which is only measured in research laboratories, but more significantly even, small, dense LDL. There are at least two flavors of LDL, actually a spectrum, but it's arbitrarily broken down into two flavors, small, dense, and large, buoyant. And the large, buoyant LDL is harmless, whereas the small, dense LDL has indeed been shown to be predictive of atherosclerosis. Now, what usually happens when you normalize blood sugars is that the LDL, after a few months, changes from small, dense, or cardiotoxic, to large, buoyant, which is benign. And what probably happened in the case of your daughter is that not only did she have this conversion, but she ended up with more of the large, buoyant particles, which are less dense. Probably the total mass of LDL, because these are less dense, went down, even though the total number of particles may have gone up. In any event, the only way you could find anything more significant would be if at the beginning you had checked for the particle density, and then on the follow-up blood draw had also looked at particle density. I do this routinely on every new patient. So before a patient even comes in here, I see his lab report, and I know whether he's mostly small, dense, or mostly large, buoyant. And we actually get a number that for each of those. So looking at total LDL just has no meaning. Now, many doctors are using any increase in LDL as an excuse for not controlling blood sugars or for not following low-carb diets. And it's just not a valid excuse, and it demonstrates lack of knowledge of the true risk factors for heart disease. After flying with my insulin in my suitcase, I found that it didn't lower my blood sugar. I luckily had another vial with me, but it would have been good to know there may have been a problem in advance. Is there something you can recommend? Well, I can, I don't have enough information to really answer his question, but I could point out that if your insulin is checked in with your luggage, if it's inside your check-on luggage, the luggage compartment is going to be exposed to the atmosphere at 20 or 30,000 feet, which is very, very cold, and the insulin can freeze. That's why you don't put pets in the luggage compartment. You don't want to freeze your insulin. That will destroy its efficacy. So that could have happened if you checked the insulin. On the other hand, if you kept it in your pocket next to your body, there's a remote possibility that the heat might have inactivated it. I think that the freezing is more likely to have happened, but you probably would be wise not to keep your insulin in the check-on luggage. This leads to a potential problem. I have historically told my patients, take duplicate supplies for the treatment of your diabetes and any other medical conditions you may have, and also for traveler's diarrhea if you're heading to an endemic area. I say put some in your carry-on luggage, put some in your check-on luggage. But when it comes to insulin, you don't want to put it in your check-on luggage. So I would say what you do is put a vial in an outer pocket of a jacket in addition to one in your carry-on luggage. What are your thoughts of carrying a pre-filled syringe for lunch when not at home? Well, that's just what I do when I go out for dinner. I don't take a whole vial of insulin and draw the dose out at the dinner table in front of everybody. What I do is take a syringe that's pre-filled a little above the dose that I expect to use, and then at the dinner table I'll squirt out the excess. I take a little just in case I overeat, which I try not to do. So I squirt out the excess, and I actually take 2 of these syringes in case I've bumped against them and inadvertently squirted out insulin from one of them. Now, you could take a pre-filled syringe case and this won't happen, but because the pre-filled syringe case is a little bulkier than each of the 2 pre-filled syringes, and I don't want a bulge in my pocket, I put 2 syringes side by side in the outer jacket pocket. And I recommend this very highly. To maintain your low A1C, how many times on average do you inject yourself with your low doses of insulin? Well, even though I take Tresiba insulin, where they claim it lasts for 2 days, I find that it barely lasts overnight, and I have to take 1 shot in the morning and 1 shot at bedtime. So that's 2 to start. Then I take a shot of regular insulin for each meal, and it happens that I'm so busy, usually with patients, that I don't have time for lunch. So I have dinner and breakfast, and I take a shot of regular for each of those. Now, once in a while, something might happen that will send my blood sugar above my target, and I might want to give myself an intramuscular shot of diluted insulin. And I would say maybe one of those every 2 days. So that gives me 4.5 shots a day on average. Should we be concerned with the M-cresol, that's preservative, that seems to be in all insulins? Well, I would say probably not, because I've been taking insulin for, I think it's 72 years. And I'm in pretty good shape. In fact, I'm in better shape than any non-diabetic I know who's within 10 or 15 years of my age. So I don't think I'm suffering from it. I haven't done any controlled studies over large populations, however. Which basal insulin do you recommend now that we have a number of choices? If a child, does it make a difference which one to use? Well, I've just rethought the basal insulin because of the new diluting fluid. You can now, it's not a new fluid, but it's now being used for Levemir. Up to now, I would have used, depending on the size of the child, either very small doses of Tresiba or multiple shots of diluted NPH. Now what I recommend is diluted Levemir. Now, I have no experience on the action time of the diluted Levemir, and the manufacturer claims they have not done any studies. So there is a question mark, and maybe the diluted Levemir will not last as long as the undiluted Levemir. I just don't know that. Because my Tresiba doesn't last the whole night, and even when I was taking Levemir, it didn't last the whole night. I would get up. Usually I wake up around 8 a.m. I would get up at about 6 a.m. To take my morning shot of Levemir, and I get up at around 6 to take my morning shot of Tresiba in order to avoid the dawn phenomenon. And with a kid, if you want to avoid the dawn phenomenon, you might have to give him a shot, say 6 or 7 hours after his bedtime shot. Are there any differences between Humulin R and Novolin R? There should not be. I've had patients use them interchangeably depending upon what their insurance, their medical insurance would pay for. The two insulins are supposed to be identical, chemically identical. So hopefully there's no difference. I've never heard any reports of any difference between the two. Anything to a treatment proposed by Dr. Serkis of sodium bicarbonate and molasses dissolved in hot water for treatment of diabetes? Well, I would think it's a good way to cause ketoacidosis in patients who are insulin dependent, and to give very high blood sugars to type 2 diabetics. That's about all I could say. Type 1 5-year-old on your 6-12-12 diet. Well, right off the bat, for 5-year-olds, I would not recommend my 6-12-12 diet. What I try to get kids to do is to scale down, or parents to do, is to scale down the carbohydrate based on the weight. The 6-12-12 is typically for someone who weighs about 130 or 140 pounds. And if you weigh, let's say 14, well, in a 5-year-old, let's say you weigh 30 pounds, you would only be taking something like 1, 2, and 2, or 1, 3, and 3, not the 6-12-12. She has a high level of ketones in the urine. Should this be worsened with a sugar of 9.2 millimoles, which is 166 milligrams per deciliter? Well, it's the blood sugar that you should worry about. If you're walking around with an average blood sugar of 166 milligrams per deciliter, you're guaranteed over time to develop the long-term complications of diabetes. And this kid will develop gastroparesis early on, just like I did. I was 12 years old. And the gastroparesis can make it impossible to control blood sugars thereafter. So the problem here is not the ketones, it's the high blood sugar. There are too many people measuring ketones. Ketones are essential for the survival of the human race. They're caused by starvation or fasting. So if you don't eat overnight, there's a very good chance that you'll have ketones in the morning. In fact, virtually 100% of pregnant women who don't eat overnight have ketones in the morning, and it doesn't seem to harm either the woman or the fetus. There are just too many people going around with blood ketone meters. I don't think I've ever measured my ketones in either my blood or my urine since I've been controlling my blood sugars. Back in the old days, when I was in and out of ketoacidosis and had blood sugars as high as 1,500, I was checking ketones. But since getting my first blood sugar meter and figuring out how to normalize blood sugars, I've never checked, and I've survived pretty nicely. Okay. I'm a low-carb type 1 with Hashimoto's thyroiditis. That's autoimmune hypothyroidism. Cheese sends my blood sugar up. 1 ounce can increase blood sugar 20 milligrams per deciliter. I stopped eating cheese, which I love. Curious, what causes this? Well, this person should read my book, Diabetes Solution. He'll learn that there's something called gluconeogenesis, where you convert protein to glucose. And every slice of cheese requires insulin to prevent that from happening, or to prevent the glucose that you got from the protein from raising your blood sugar. Also, each slice of cheese has 1 gram of carbohydrate. If you're getting a standard slice of pasteurized processed cheese, it's got 1 ounce of protein and 1 gram of carbohydrate. I find that I need approximately a half a unit of insulin per ounce and an eighth of a unit per gram of carbohydrate. So it's very explainable. It's no mystery, no reason to stop eating cheese, but you don't eat cheese as a snack. You eat it as part of a meal and cover that meal with insulin. Next is type 1 for 18 years in medical school. Stopped using the pump because of scar tissue, but now I believe I'm getting gastroparesis and have high blood sugars in the morning and low readings at night. Should I go back to the pump? Willing to do anything. Well, it's a lot easier to read my book than to go back to the pump. And that's what I would suggest you do. Read Diabetes Solution. It gives you step by step everything you need to do. There's also a chapter on treating gastroparesis. I'm not just starting your diet. No, I am just starting your diet, and I wanted to know how long it takes for sugar stores to be depleted. This is another meaningless question. We can say that glucose is stored in the form of glycogen, a starch or a polymer of glucose, in muscle and in the liver. And the total weight of glycogen in a typical adult is about 300 grams. That would be about 1,200 calories. So people are walking around with glycogen stores worth only 1,200 calories, which is not going to last a long time. If you're of average physical activity, it might last you 1 to 2 days. If you're very active, it might last much less than that. So that's basically the story. I would say that you should read my book, Diabetes Solution. It explains this. And that's basically it. You don't, if you use up all your glycogen, however, I left out one thing. You still have a backup supply because your muscles are made out of protein and the body is capable of converting protein to glucose. So you'd really probably have to be dead to use up all your sources of glucose, that is to destroy all your muscle tissue, including your heart. I like to skip breakfast, and when I do, my blood sugar still goes to 240 around 10:30 a.m. from 105 when I awaken. The day and night before, I have only eaten lean protein and veggies and oil for fat. Not sure where these highs are coming from. Maybe stored sugar. Here's another myth about the stored sugar. This person probably is diabetic, number one. And if he's diabetic, he's probably experiencing the dawn phenomenon, which is described in my book. And if he has the dawn phenomenon, he probably needs basal insulin. So he should be taking basal insulin at bedtime, and again, probably about 6 hours later. And that would stop the blood sugar from going up. Now, there's one other possibility. The patient might have gastroparesis, in which case they tend to go too low after dinner, not every night, but many nights. And then, because the stomach didn't empty fully at dinner time, and then the stomach finally empties maybe when they get up in the morning and start walking around, and that causes the elevated blood sugar. But I think this is more likely the dawn phenomenon. Read the book. On ketogenic diet for over 2 years. My sugar came down, but I am not losing weight or inches. Showing ketones consistently. Can you shed any light on why I cannot lose weight? Should I just have patience and it eventually will happen, or am I doing something wrong? Well, I have one guess. There's now a wave of ketogenic diets which make no sense to me, where doctors or crazy people on the internet tell you to eat a lot of fat until you show ketones in your urine to demonstrate you're metabolizing fat, and then you will lose weight. Eat low carb, a lot of fat. You can eat low carb, but if you go overboard eating fats, you can undo the benefits of the low carbohydrate. So I would say that you stay away from any of these fatty products that are advocated for ketogenic diets, oils, butter, cream, etc., etc. My guess is that your ketogenic diet is one that's forcing fats upon people. And what I do is deprive people of carbohydrates that raise blood sugar, but also build fat via hormonal mechanisms. But adding a lot of fat to your diet is going to build fat. Can't find any docs to do an RS interval test to diagnose gastroparesis. Is there any other test, like a gastric emptying test? No, there isn't. In fact, a gastric emptying test is very problematical. When I first started in practice, was doing gastric emptying studies whenever I suspected gastroparesis. And typically, I had to get four studies before I would get a positive result, before I could make a diagnosis. We'd get 3 negatives, and then maybe we'd get a positive. Now, how did I get patients to afford 4 of these expensive studies, one after another? It was because the country's authority on gastric emptying, Richard McCallum, was then at Yale, which is not far from where I am, and he had a grant to do gastric emptying studies, technetium scans, and it wouldn't cost my patients anything. And if I sent him a patient and he got a negative, he might have them come back a few days later, do it again. And we found that it might take four different studies before the delayed emptying showed up, because the hallmark of gastroparesis is unpredictability. If you get unpredictable low blood sugars after dinner and highs in the morning, where it doesn't happen every night but happens some nights, you can be pretty sure it's gastroparesis. Now the next question is, who does RR studies? In response to this question, I did a search on the internet, and the first name that came up was me, which amazed me. And there were so many responses, most of which were journal articles and not the names of practitioners. So, and I didn't have time to look for all of the responses that I got when I used my search engine. So what I'd suggest you do is take out your search engine and look on the internet for what doctors perform RR interval studies. You may find someone and you may not. I just don't know. This is a routine test in research studies. And if your doctor either participated in the DCCT trial or in the Accord trial or of a number of other large-scale clinical trials on diabetics, then there's a good chance he or she may know how to do RR studies. I've run into several physicians who knew how to do it because they were active in these trials. They weren't doing it routinely, but they had never thought of doing it. I am a type 1 diabetic with poor control, poor eating habits, extremely busy lifestyle. I'm interested in transitioning to low-carb diet, but concerned about hypoglycemic episodes and my ability to actually stick with a diet, especially when I'm craving a cookie. With these concerns in mind, what are your suggestions for starting a program? My main suggestion is reading my book, because it's geared toward achieving normal blood sugars without hypoglycemia. If you're on a low carbohydrate diet, you have to cut way back on insulin. That's number one. You also have to cut out insulin pumps because you get unpredictable absorption when you have scar tissue from insulin pumps. We have several suggestions in the book for how to curb overeating. So the suggestions in the book involved a class of drugs called GLP-1 agonists. And we've discussed this in my teleseminars and in Diabetes University. There's something that I've been discussing more recently on both teleseminars and Diabetes University, and that's Bauhinia, an herb that you can purchase from the people who sponsor my teleseminars. It makes you feel full. You take a few teaspoons in water before a meal, and you feel prematurely stuffed and don't want to eat very much. There's also something on the internet called the Pavlok, P-A-V-L-O-K, where you train yourself like Pavlov did with his dogs. Every time you violate the rules of no snacking, you give yourself a little electric shock, and you gradually increase the shock every time you violate. So that's another trick. What does a person with chronic low blood sugar need to do to feel more focused and energized? He shouldn't have chronic low blood sugar. And the way around it usually is a high protein diet. There are people who have reactive hypoglycemia. There are also people who, reactive means that after they eat carbohydrate, their blood sugar plummets. First goes up a little bit and then down a lot. It's a pre-diabetic condition. Then there are people who just may always be making too much insulin, which is also a pre-diabetic condition where the body does not respond properly to blood sugar and may be making insulin even when the blood sugar is low. But the one way around all of this is a high protein diet, and frequently even frequent protein snacks. So you might have relatively small protein snacks all day long. And it's not a matter of getting adapted to the low blood sugar, it's a matter of preventing it. Is chronic hypoglycemia a precursor to diabetes? Frequently, it's probably asked by the same person who asked the prior question. It frequently is, yes. Can levothyroxine increase fasting blood glucose? My doctor says no. Can you explain how that happens so I can educate my endo? Well, I really had to think about this one because I haven't seen any articles saying that levothyroxine, which is T4, a hormone made by the thyroid gland, brand names include Levothyroid and Synthroid, but there are some people where T4 can block T3 receptors. T3 is the active thyroid hormone. T4 is only somewhat active. It gets converted by enzymes in the cells to T3, the really active hormone. But some people have T3 receptors that can be blocked by T4. And if you block the T3 receptors, then the people will become chronically hypothyroid, sluggish, slow, will not be getting as much activity or physical exercise, the heart rate will be slow, and because everything slows down, the blood sugar might go up. That was the only explanation I could think of. And I'm willing to bet that very few other people would have thought of that explanation. Is taking alpha-lipoic acid safe? Which form? Will it help with high fasting blood sugar? I doubt it, but there is some mild evidence that it might lower insulin resistance. So there's a possibility. There's a company in Florida that makes a product called Insulo, Insulow, that you could experiment with. I don't know whether it will be of any value, but and I also don't know how big a dose is potentially dangerous. I do know that the alpha-lipoic acid comes in two mirror image forms, or enantiomers they're called, R and L for right and left, and the R version is more potent than the L version, and Insulo contains the R version. But again, I'm not recommending it. I'm just saying that it's something that you could experiment with, see if it makes a difference. The doctors who prescribe low-carb diets for diabetics often strongly recommended unlimited use of butter, cheese, fresh cream, paneer, I don't know what paneer is, which are all dairy products. On the other hand, diabetics are not supposed to take dairy products. Please clarify these contradictory opinions. Well, first of all, I don't know why diabetics are not supposed to take dairy products. Maybe it's because the American Diabetes Association is so down on fats. Now, I might qualify that. They now are disclaiming their aversion to fats, but all of their meal plans and recipes and whatnot avoid fats like the plague, and they still promote high carbohydrate. But there's no reason to avoid fats, and there's no reason to stuff yourself with butter unless you, especially since we don't want you eating bread or crackers. What are you going to put or potatoes or corn, what are you going to put the butter on? Just eating butter for the sake of butter doesn't make any sense to me. And likewise, drinking fresh cream just for the sake of drinking cream doesn't make any sense. So this looks like some doctors are giving you a lot of nonsense. I would say that you read my book, Diabetes Solution, or Diabetes Diet, and you'll see what a reasonable diet for diabetics looks like. For running and training for marathons, would you advise honey along with water inside a flask instead of liquid glucose? I have issues with the taste. Endurance athletes generally have problems with gastric issues if taking something not suitable for them. Well, if you're in a marathon, you want something, and your blood sugar drops, you want something that's going to work rapidly. So you don't want to take honey because it's a mixture of sugars, including fructose, which are too long-acting. The fructose might not significantly affect your blood sugar until the race is over. So I suggest liquid glucose. Now, there are many flavorings that you could use. In fact, you could literally make your own. You don't have to buy it prepackaged in bottles. This is what I use, but you don't have to buy it. You could make it yourself. You buy a glucose powder on the internet. It's very inexpensive. And then, instead of using water, you could use one of the flavored liquids. For example, I very much like Da Vinci cookie dough syrup and Da Vinci toasted marshmallow syrup. But they have like 30-odd flavors. And you could pick a flavor you like and dissolve the glucose powder into that flavor. Or you could use some water with Walden Farms chocolate syrup, a little bit of the chocolate syrup and a lot of water, and you could get a taste that you find pleasant. That's what I would recommend. Endurance athlete cannot stop delayed post-workout low blood sugar. For me, it tends to happen around 4 hours after the session. Well, I could think of several possibilities. One possibility would be to get a continuous glucose monitor. In fact, that would be a must, so that you don't go dangerously low before you can catch it. And it would also be helpful during the run. I also suggest you read my book, Diabetes Solution. You might want to eat a portion of a protein bar, which, although they're labeled protein bars, they usually contain as much slow-acting carbohydrate as they do protein. So they will relatively slowly raise your blood sugar. But you have to be careful not to overdo it. So you get a continuous glucose monitor, and at the same time you eat half of a protein bar and see what happens. And also check your blood sugars frequently, maybe every hour, maybe every half hour. 1 gram glucose exists in the form of sweet tarts, candy. Is there any reason not to use it? You could double check the possible reason. I understand that sweet tarts contain maltodextrin and that they each contain about 1 gram of glucose. The 1 gram of glucose is fine for treating hypoglycemia, but if there's also a half a gram of maltodextrin, which is slower acting, you're not going to get the effect you will get from pure glucose. I might add that I have a group working on developing 1 gram glucose tablets, which have been taken off the market by one manufacturer, but I have someone else working on an alternate source. Can you give us examples as to what a 6-gram carbo breakfast is? Well, you could use cheese. 6 ounces of cheese would have 6 grams of carbo. You could use nuts that have low glycemic indices, like macadamia nuts, pistachio nuts, almonds, walnuts. These, small number of these nuts, you weigh out a portion according to a table you can get on the internet, and cream, which you might be using for coffee. Each tablespoon has half a gram of carbohydrate. So these 4 things, and you could put vegetables in an omelet, or you could just eat the vegetables. So there are a number of things that you could use to get 6 grams of carbo, or you could combine them. Okay. Well, I think we've come to the end of our session. thanks for listening. The next teleseminar will be in July, let's see, Wednesday, July 26th, 2017. So have a good night or a good day, depending upon where you are in the world, and thanks for listening. We'll see you again soon. Hi, this is Dr. Bernstein with a special broadcast just to thank the people from Type 1 Grid for the birthday present that they sent me. For my 83rd birthday, they sent me a video thanking me for my books and for the help I've given them via my videos and so on. And they waited for the 83rd birthday because my target blood sugar for all adults is 83. Now, what they're going to do when the 84th birthday comes along, I don't know. I'm not going to raise the target. So we're stuck with 83 as our target for adults and 70s for the target for kids. And 100 different people gave short statements of their medical histories or their gratitude for the help. And this was unbelievable. It was the best birthday present I've ever received. When my kids were little, we used to ask them to guess whether this present is to eat, wear, or play with. And this one was none of the above. And it beated the best present I ever got in the past, which was when I was 16 and graduated high school. My parents got me a Buick Special convertible. It was the first year of wraparound windshields, and about 1 or 2 years prior to the end of wraparound windshields. So it was a very unique car. But this gift of 1 hour of thank yous and thank yous way outdid the Buick. So again, I thank you. I also want to thank the many people who sent me birthday cards, which came from all over the world. Thank you so much. I really appreciate them. And I play the video over and over. Thank you.